Good afternoon, everyone, and thank you for joining me today for this webinar on CBT telehealth adaptations for providers of for people who provide mental health services for Latino populations. So I was really excited to do this webinar because it's being done in collaboration with the National Latinx Psychological Association, and I just wanted to remind everyone that there are other sponsored webinars through MHTPC and the NLPA that are occurring next week as well. For example, on Monday the 18th, we'll have a webinar on telehealth adaptations for motivational interviewing with Latinos. So I really encourage you all to attend some of those talks as well that are happening in the weeks to follow. We can move on to the next slide. I just wanted to give you a little background before we get started on my own experiences of telehealth. And so those experiences first began when I was a postdoc at the Medical University of South Carolina. And that's where I provided trauma-focused cognitive behavioral therapy to children and families who had experienced some kind of traumas in their life, ranging from sexual abuse to immigration trauma, to car accidents and things like that. So I didn't first start doing telehealth. I actually started doing outreach services by going to the homes of these children and families. And once I made the transition to telehealth, the difference was pretty amazing. At first, I of course have to say I was hesitant about the change from in-person to telehealth services, but I quickly realized that in many ways the interactions with the clients that I had remained the same in terms of the level of rapport that I was able to maintain with them, and in seeing clinically meaningful change in the symptoms and for the positive outcomes in the clients over time. I now supervise clinical students, so doctoral students in a clinical psychology program at the University of Texas, Rio Grande Valley. I'm supervising them in their first semester doing clinical work. And as a result of COVID-19, they've actually had a transition from seeing patients and clients in person to online. So I'm going to talk a little bit about that as well. Now, I'll be speaking about telehealth, of course, and there's plenty of information out there on the logistics of starting out doing telehealth services with your clients. But I'm going to focus more on how to use telehealth services to increase access for Latinx populations and how cognitive behavioral therapy tools can be adapted for telehealth. And our last learning objective is to identify cultural and linguistic considerations for Latinx populations using telehealth. So I'm more than happy to answer any questions about logistics of using telehealth during the Q&A portion of the webinar. So feel free to ask. Next slide. Sorry, next slide after learning objectives. Great, we're going to start with the first one and get into some information that you might already be familiar with regarding mental health disparities. Next slide. So, one more back. Great. So what we know overall is that most racial and ethnic minority groups have similar, or in some cases, fewer mental disorders than white populations. However, we also know that Hispanics and Blacks who do become ill tend to have more persistent disorders and experience more disability due to their mental illness. Latinxes also are less likely to access mental health services compared to whites. For example, in the National Survey on Drug Use and Health, they found that for Hispanic populations, only 8.8% of individuals over the age of 18 received mental health services in the last year, compared to 18.6% of non-Hispanic whites. So that's more than double the amount of individuals seeking mental health services compared to Hispanics. And lastly, we also know that Latino populations are less likely to receive quality care or guideline congruent care compared to non-Hispanic white populations. So we see a number of different ways that Latino populations are impacted by mental health disparities in terms of access to treatment, delaying seeking treatment, and dropping out of treatment as well. Next slide. And these are due to a number of barriers that have been identified in the literature in terms of accessing mental health services for Latino populations. And we can kind of conceptualize them as issues of accessibility, issues of availability, issues of appropriateness, and of affordability. So what we have on the right-hand side are just a list of some of the barriers that you might all be familiar with that keep Latino populations from successfully accessing mental health services. So things like accessibility include being able to take time off work, and scheduling issues so that you can go in to an office-based service. Things related to availability include not living in an area where there are mental health providers available and services that you can access. And this happens often with rural populations. Appropriateness has more to do with the lack of culturally and linguistically appropriate services available for Latino populations. So not having providers who speak your preferred language, if that's Spanish, or not having providers who are providing treatments that are culturally sensitive. And then affordability issues, of course, are related to things like cost or lack of health insurance that prohibit many from getting services. Next slide. So the telehealth model of care in many ways can increase access to quality evidence-based services for Latinos by addressing some of the barriers that I mentioned in the last slide. One of them being that clients can be seen from a variety of remote locations with telehealth. That means clients can be seen at home. They can be seen, for example, with children, they can be seen at schools. They can be seen in primary care clinics. They can pretty much be seen anywhere they have access to telehealth equipment. And the clinicians are usually located in their offices. So at MUSC in my postdoc, I was doing school-based services with children. And sometimes parents couldn't even make it to school or had a really busy work schedule, so they couldn't even be seen at home when they were at home during my office hours. But I was often able to see mothers at work during their lunch hour breaks. So they would take the tablet with them, and we'd have about 30 minutes to 45 minutes during that lunch hour break to be able to do a mental health session with them. The next point is about cost effectiveness and telehealth being able to address issues or be able to reduce travel time, transportation cost, and missed work for clients and their families. So when I first discussed a little bit about my background, I talked about doing outreach services, which involved me driving over to client homes. And once I transitioned to telehealth, I was able to see a lot more clients during the day, reach a lot more children and families than I would have if I spent my days driving over to locations and driving back to the office. Next is increasing geographic coverage of service providers and the dissemination of evidence-based treatments. And that's because, as I mentioned before, a lot of individuals are located in rural populations where they don't have access to mental health services. But with telehealth, we can actually, one provider can cover a larger geographical distance and be able to reach populations that are underserved. And then lastly, telehealth can reduce stigma associated with obtaining mental health services. Now, I know we see this a lot with other ethnic minority populations and Latinos in particular, about being thought of as being crazy if you go see a therapist. But with telehealth, individuals don't actually have to come to the mental health clinic. And they can be comfortable at home doing their telehealth sessions with that kind of privacy of others not actually knowing that they're receiving mental health services. So when it comes to terminology, tele is usually the word that kind of precedes a discipline-specific term. So tele means to or at a distance. So we see words like telehealth being used, and in Spanish, telesalud, which is a much more broader term, and it's used to encompass a broad definition of remote healthcare that doesn't always involve clinical services. So telehealth can include transmission of still images, or e-health, including patient portals, and remote monitoring of vital signs, continuing medical education. All that could be considered telehealth. So clinical services and also non-clinical services. We have terms such as telemedicine, telemental health, telebehavioral health, telepsychiatry, and we also have telepsychology, which is the term used by the American Psychological Association in their guidelines for the practice of telepsychology, published in 2013 in the American Psychologist. So next slide, if we use the term telemental health, that would be considered the use of electronic communications between individuals and their mental health providers who are not located in the same physical place. And it's through the use of interactive video and audio communications. So you can see here that can include devices such as, or equipment such as desktop computers, laptops, tablets, and smartphones. And these telemental health services can be provided as standalone services by themselves or in conjunction to augmenting in-person services. Next slide. So what do we know about the provision of telehealth when it comes to cognitive behavioral therapies? And I'm sure most of you are familiar with that term, what the cognitive behavioral therapy is. So I'm not going to go too much in depth as to describing what it is, but with this intervention, we have seen that it is just as effective as in-person treatment for children and adults for a variety of problems like anxiety disorders, PTSD, depression, and insomnia. And there are numerous additional pilot studies that you can find if you go to the Division 12 website under their telepsychology resources webpage. They have a long list of pilot studies, so smaller case studies where they might not have a comparison group to be able to test the effectiveness of telehealth, but where they have been able to see notable improvements in symptoms with telehealth. Next slide. Now, we all know that many are now using telehealth, but what was our usage of telehealth like before COVID-19? The National Council for Behavioral Health created a report in 2018 where they surveyed a number of organizations across the United States. About 153 of them responded and said that they use telehealth and behavioral health for behavioral health services at their organization. And the majority of that telehealth usage was through direct video conferencing. Next was telephone use, mobile health, email, patient monitoring devices, and store and forward methods where a patient keeps track of their blood pressure or glucose levels, and then that gets transmitted to the provider. So most people who were using telehealth were using this direct video conferencing. Next slide. In addition to that, respondents also identified the types of services provided via telehealth, and they were specifically using telehealth for medication management. And you can see why. The majority of individuals or providers who were using telehealth were psychiatrists, then mental health counselors, social workers, psychologists, and addiction counselors. So the majority of people using telehealth were psychiatrists for medication management purposes, being the most common reason why. Next. And several things happened recently to make the use of telehealth, to promote the use of telehealth to connect mental health providers with their patients. And this all happened in response to COVID-19. So one of the things that happened was that HIPAA rules were relaxed temporarily. And this was related to the kind of telehealth platforms that you could use to connect to your patients. and that this freeing up people or providers to use FaceTime and Skype that was not HIPAA compliant. CMS also expanded telehealth coverage, and before people were not going to be able to get reimbursed for telephone only services or for services if they were located at their home, and now they can. CARES Act funding was also being provided in order to promote this telehealth service provision for providers who needed funding to be able to do this. And then there's been a proliferation of telemental health trainings online. Some of them are listed here with some links. APA has a telepsychology best practice 101 series. There's APA practice resources. MHTTC has the Building Telehealth Capacity webpage. The National Register has a clinical webinar series, and the Telebehavioral Health Institute has a clinical best practices for COVID-19 webinar training. So government, industry, public responses about coronavirus have helped make telehealth more possible now for a lot of providers. And in order to help prevent the spread of the virus and to keep both patients and providers safe. Next slide. So I wanted to talk a little bit about what we did at the University of Texas Rio Grande Valley when we had to make this transition and what our response to COVID was. So as we all know, on March 13th is when we got the national emergency announcement about the pandemic. And at UTRGV, we were actually still on spring break, so none of the student clinicians were seeing patients that week. And really within a matter of a week and a half, students were trained, consent forms were created, therapy rooms were, the layout of therapy rooms was changed so that it would facilitate telehealth sessions. And then on March 25th, students were able to begin seeing their in-person clients via telehealth. So this was a very quick transition. It's not representative of all universities or of all clinics that have had a transition. We are aware of that. Many psychology programs across the country have had to stop providing services at their psychology clinics because they didn't have the equipment available, and are going to hopefully resume providing services once in-person services are safe to do. And next slide. I have a picture here of what our clinic therapy rooms look like. So you can see the couches where the clients and the providers usually sit. But now what we see is that we've had to create workstations in the rooms with desktop computers that were not there. These desktop computers were the computers used for assessments, for example, and they were moved into the therapy rooms and equipped with web cameras. And we had telephones placed inside of the rooms so that our student clinicians could contact patients and help them troubleshoot connecting to the telehealth platform. Next slide. So I'm going to move on now to talk a little bit about how CBT tools can be adapted for telehealth, because you're probably wondering, you can have all the logistics set up, but what kinds of tools and activities do you use in your sessions, and how can you actually transition them to telehealth? Next slide. So yes, I want you to think about your clinical work. I want you to think about the services that you provide and all the activities, all the tools that you use with your clients in session, the things that you would normally do in person. So I want you to just take a few minutes to think about the tools that you use. Next slide. So here's just some images, some examples, right? Things that we might use in therapy, cognitive behavioral activities, resources that we would use with clients face-to-face. So these can include books, right? Using a whiteboard to help clients go through challenging, unhelpful thoughts and generating alternative helpful thoughts. Psychoeducational handouts and worksheets that we complete with our patients and clients. Next slide. So here's a more broader list, a list of other things that we do when we are providing CBT to our clients. We use self-report measures, right, to track symptoms and to know that the treatment is working. We have self-monitoring forms and thought records, client handouts, worksheets. We do activity scheduling for behavioral activation. We assist clients in vivo exposures. We use audio recordings for imaginal exposures. We demonstrate relaxation techniques and we present videos. So despite the strong evidence that CBT interventions are highly efficacious in a variety of mental and for a variety of concerns, they frequently rely on written materials and between session assignments. And that can sometimes be a barrier when we think about how we do these things via telehealth. And we'll talk a little bit more about that specifically for our limited literacy clients. Next slide. So how do we transfer the tools and how do we move beyond just the how-to for setting up telehealth services? Next slide. I want to talk a little bit more about the technology and how we can use it to our advantage in order to still provide the same quality services using very similar tools and activities that we would use in session and transition them to an online setting. So many platforms, or not all of them, but some of them have this whiteboard function that you can utilize to help clients still interact with you in your sessions. On the right-hand side, you can see a body outline. We're filled in with different colors, and this is something that I would do with some of the kids I was working with for TF-CBT. We would identify where in their body they felt certain feelings. And so you can see the red is filled in the person's hands and their head because this child said they felt angry when they would make fists with their hands and their head hurt. So they were still able to color in and identify where in the body they can feel those feelings, those physiological reactions, and be interactive and engaged in treatment. There is also a screen sharing function that many platforms have. At our clinic at UTRGV, we're using Zoom. And of course, there's many platforms out there with screen sharing functions. Video is another one. But if you can still share the handouts, why not? If you can share them on your screen. It can be a great way to use visual cues to help you with going through relaxation exercises, for example, with some kids. But using these functions can help facilitate the use of those CBT tools we talked about earlier. Next slide. Another feature that some of the platforms have is the ability to use the chat function. So I'm sure many of you have been in online meetings after COVID-19 and perhaps maybe some experience using this chat feature to ask questions during the meeting or to share materials, but we can do the same thing with our clients via telehealth. We can use that chat function to send clients links to psychoeducational videos and we can watch them together with the share screen function. We can send web pages and a behavioral activation worksheet. So you can also send files through the chat function as well, at least on Zoom. Next slide. I highly encourage you to still use those handouts that are your go-to handouts and worksheets in person. And these can be easily formatted to become fillable PDFs, where you can serve as the scribe and write in the client's responses for these worksheets. In the end, you can save them and you can even send them to your clients so that they have a copy. So this can be a good way of still maintaining that activity and not foregoing the use of those CBT tools that you usually use in session, because they can still be used. And then PowerPoint has actually been one program that I've used quite often for creating psychoeducational presentations, for also creating interactive kind of worksheets and tools with clients. For example, the image you see at the bottom, those 4 colored squares are basically a psychoeducational PowerPoint trying to explain the symptoms of trauma like re-experiencing symptoms, avoidance, just using images. And so PowerPoint has been able to facilitate that. Next slide. Using telehealth comes with some advantages that we might not actually consider when we're doing in-person office-based sessions. And one of those advantages is being able to see your client in their home environment, if that's where you're seeing them. So that gives you a lot of rich information without having to do a home visit in person. So with telehealth, for example, you can manage temper tantrums in vivo if you're teaching a parent parenting skills. So when the disruptive behavior occurs, you can help coach and guide the parent in managing their child's behavior. And when it comes to in vivo exposures, we're limited to what's in the office when we're doing them in session. And clients usually have to do in vivo exposures for homework on their own, and we're not with them. But with telehealth, they can actually bring us with them if they have their equipment. So taking the telehealth device on in vivo exposure assignments can be a new way to help clients with their exposure treatment that we might not have been able to do before if we were limited to what we could do in the office with images and imaginal exposures, for example. Next slide. So I wanted to provide you all with some resources that I think would be really helpful, especially if right now you're looking for some guidance on how to adapt CBT tools to telehealth. And the Medical University of South Carolina, the Telehealth Outreach Program is where I did my postdoc. They've developed a website that has a list of resources there, handouts and worksheets, even a 2-part webinar series on the logistics and specific tips on doing TF-CBT via telehealth with children and families. But I think that a lot of the resources on that website can be applied or can be used to see children and families with other kinds of problems. For example, TF-CBT has PRAC components, which involve psychoeducation, relaxation, affect modulation, cognitive coping, and those are some of the things or skills that we teach children and families in other types of treatments, not just TF-CBT, and they can be utilized in other kinds of, for other kinds of presenting concerns. And I've worked with the team at MUSC to write a manuscript that we have in press about resources and recommendations for engaging children and adolescents in telemental health interventions during COVID-19 and beyond. So these are more general recommendations about how to keep kids engaged in treatment and keep it, interactive and fun for them so they can still benefit from it. Next slide. Here's an example of some of the tools that are found on the Telehealth Outreach Program website. And what you'll see is ways to kind of include some kind of game or game-like interaction to keep kids engaged. So, for example, there's a feelings charade tool in PowerPoint that you can use to help children identify how they feel what they feel when they feel happy, or what they do when they're angry, in a fun kind of way. And then, like I said, PowerPoint can be used to make behavioral contingency maps as well. So there's lots of tools on there. I really encourage you to explore them on the website in the link provided in the earlier slide. Next. Let's move on now to some more cultural and linguistic adaptations and how that may interact or impact the way that you provide CBT via telehealth. Next. So I do want to say that it's really important to consider the acculturation level of your clients, to consider their comfort and access and use of technology at baseline, to see whether or not you're going to encounter specific kinds of barriers to doing telehealth with your client. For example, many falsely believe that Latinx populations don't have the same access to, or we don't use technology at the same rates as other groups. But what we actually find through the Pew Research Center is in a survey, Latinx populations were less likely to own or have a desktop or laptop computer, but they were just as likely to use smartphones to access the internet and to interact with that kind of technology at the same rates as other groups. However, I want you to consider if your client, it might not have a desktop or a laptop screen or tablet screen, and they are only actually able to access a smartphone for telehealth, then think about that screen size, how it's so much smaller and might not be the best way to share resources through the share screen function, for example. So you wouldn't want to rely so heavily on handouts and worksheets that are fillable and need to be read by the client if they are really only being seen on this smartphone screen. That might not be the best way to go. I want you to think about how you might teach your client, or you might need to teach your client how to use the telehealth platform. So although individuals might be well aware of how to use their technology for video chatting or for other social media, they might not know how to use the platform for telehealth purposes. And one of those things includes maintaining eye contact or being able to look at the camera of your equipment to maintain that direct eye contact with your mental health provider. Next slide. Other Latinx cultural considerations include whether or not your client is a part of a multi-generational household. So for our older clients, or for those who do not have experience with telehealth, if they live in a multi-generational household, you might require the assistance of another member in the household to help them utilize the platform. So on numerous occasions, when I was seeing children and families, perhaps the parent didn't know how to use the telehealth equipment or wasn't familiar with the technology, but the child was able to help us in initiating a call or turning off the tablet or closing the application at the end of session. So think about how you can utilize those multi-generational households to help for family members to help each other out if one has less knowledge about the technology than another. You want to also consider that in some Latinx households, there are multiple families living under the same roof, sharing the same spaces. And it can be quite difficult to find a space at home where you would have the privacy you would want in order to do a mental health session with your provider. So think about how you can help your clients troubleshoot with their family members so that they can give them a private space for just that hour session or however long you meet with them, and give them that privacy that they need for the session. But think that this might be a problem or a barrier that you come across. I want you guys to also consider some cultural values like familismo. I mentioned this because individuals high in familismo might have many family responsibilities and might prioritize family responsibilities over their mental health services, not because they don't think they need mental health services, but because what the family needs trumps everything else in that moment. For example, I'm supervising a student who has a client, and the client is the only one in her household who has a driver's license. And she's the only one who can provide transportation to the family members she lives with. So when it came time to connecting to her telehealth session, oftentimes she was driving and she couldn't. So this is something to think about with these individuals who have a lot of family responsibilities. They might need help with finding the time for their mental health sessions, even though they don't have to come to an office. And then for those who really want family involved in treatment, you can consider how that might work using a telehealth device, how we can see both of the individuals, or when we should bring in the individual to the room so that we can collaborate with them, helping the client remember to use their relaxation skills, or helping provide support in other ways. Next slide. I want you to also consider how you can develop and build trust and rapport with your clients via telehealth. And that personalismo is one of those cultural values characteristic of Latino populations, that ability to develop the warmth with your providers and have those kinds of interactions with them. That might be difficult if the first time you meet your client is on telehealth. So if we were thinking about telehealth and we weren't necessarily considering COVID-19, I would recommend doing an initial in-person session for your intake interview, for your evaluation of the client, and that provides you an opportunity to show them and demonstrate to them how to use their telehealth equipment before you move on to in-person, before you move on to telehealth sessions, because that can help, those initial interactions can help you build that rapport. But if you don't have that opportunity, then you might want to dedicate additional sessions to be able to develop that rapport and give you all time to develop that trust with your patient. Next, I want to think about telehealth communication style and how direct eye contact can be something that is a cultural thing. So, and a sign of respeto, where one example I have is of a teenage boy who I was seeing in person at his home. He would not have any direct eye contact with me. It was mostly a sign of respect, talking to mom about it and talking to him about it. But once we transitioned to telehealth with him, he seemed much more comfortable to look at the camera, to look like he was looking at me, because there was some physical distance between us, and that seemed to put him at ease. So in some ways, telehealth can be helpful for that, but I wouldn't take that lack of direct eye contact as something that would keep you from being able to develop rapport, to be able to do your treatment with that person. Think about emotional suppression and how a lot of our clients, think that they have to be strong and might have some attitudinal barriers about how they might be perceived if they show their emotions. And when we're doing telehealth, we really are relying on nonverbals. We're really relying on what's happening here with the face, because that's all we can see using telehealth. So you might want to think about those kinds of considerations. Next slide. And as was mentioned before, many of these cognitive behavioral tools rely or require on some degree of literacy for our clients. Them filling out paper worksheets and handouts, or doing activity scheduling, or the self-report monitoring forms that we use. So there's strong evidence that CBT, relies on these things that it can be effective, but it can serve as an impediment for clients with limited literacy. Next slide. Oh, language considerations, great, right there. Can you go one back? For example, limited English proficiency clients often are not given handouts and worksheets because providers think that it is too difficult to utilize those same tools with them. We surveyed clinicians, about 75 of them, at the University of Arkansas, and the majority of them reported believing limited literacy decreased the effectiveness of CBT for adult clients, and reported that they'd be less likely to provide psychoeducational handouts or tracking sheets for clients who struggle with literacy. And that's consistent with others who say that limited literacy can reduce treatment effectiveness in especially Latino populations, which are already an underserved population. So one tool that's out there is Lorraine Benito's book about resources and many CBT tools that can be utilized for Spanish speakers in their preferred language. I want you to consider how many Latinx immigrant clients might speak indigenous languages. I had a client who spoke Hmong, and we needed to use interpreters. And interpreter use can still be done via telehealth, right? We have interpreter services over the phone, or they can be in person, but there's also translation apps and other kinds of technology that can help bridge the gap in communication. Next slide. Additional language considerations are, yes, limited functional literacy. So at the University of Arkansas, they have resources at the Dream Lab website for CBT tools that can be used with these kinds of clients. And as you can see, they utilize a lot of visuals, visual analog scales to help clients still do their behavioral tracking, their homework tracking, their symptom tracking, whatever it is. These handouts are very simple. They're templates that can be customized to the individual client. So I wanted to put here a resource that you can access if you are working with a limited functional literacy client over telehealth, because these kinds of resources can still be used. Next slide. So like I mentioned, visual analog scales or any other kind of visual aid can be used for repeated assessments. So when you're tracking symptoms of trauma or depression or anxiety with the PHQ-9 or the GAD-7, the AIM Center has a visual aid for the PHQ-9 where you see this bar that is gradually filled until it's all gray, all grayed out, meaning that's how much the problem has bothered you. And the UCLA PTSD Reaction Index for DSM-5 utilizes a calendar to help clients understand how many days out of the week, out of the last month, they experienced a particular trauma symptom. So these are great ways of still doing symptom monitoring with limited literacy clients or limited English proficiency clients via telehealth, using that share screen function. Next slide. And the last thing I wanted to say about the technology was that we can use other ways of communicating with these limited functional literacy clients. So I had an 18-year-old who I was seeing via school-based telehealth, and she needed to know when to go to the counselor's office to get connected to me via a laptop. And she didn't read or write Spanish or English. She only had 6 months of education before she was victimized and left her country, left Guatemala and came to the United States. So she had limited functional literacy. And what we decided to do was create a system of communication using emojis. So I would send her this emoji of a lady behind a laptop to kind of signal to her that it was time to go to the counselor's office at 8:30. And she would either send me a smile or a thumbs up and let me know that she got the message and she was heading over there. So definitely a way that you can help clients with their appointment reminders, even though they have limited functional literacy. Next. So I want you to remember how telehealth can address some of the barriers that we mentioned previously, barriers in accessing traditional office-based mental health services. Telehealth comes with its own considerations though, right? So although in some ways we address some barriers, we need to consider how we're using our CBT tools with the equipment that the client has, with their cultural values, taking into account their limited English proficiency, if that's something that they're dealing with. But in general, I would say CBT tools can easily be adapted for use online. It takes a bit of creativity from us as mental health providers, and it takes a bit of practice with us to get to know our technology so that we can help the clients best utilize it as well. And then there are definitely cultural and linguistic factors that can impact your approach with Latinx clients. I encourage everyone who has developed their own resources to share them with others so that we can move forward with this use of the telehealth service delivery model so that we can access populations like Latinos who are underserved populations and increase access to mental health services. Next slide. So I want to thank you so much. That's the end of my presentation, and I'm happy to answer any questions about telehealth or CBT tool adaptation.
Hello, Bianca. Thank you very much for your presentation. We have a question. What equipment is needed to ensure client confidentiality?
So HIPAA compliant platforms are available through if you have a clinic, they need to set up a business associate agreement with the providers of that platform. And there are several of them out there. I know that Zoom, there's a HIPAA compliant version of Zoom. And there is a HIPAA compliant version of a platform called Vidyo, VIDYO. And there are several others out there like DoxyMe. You'd have to have that business associates agreement with that platform in order to make sure that you have the HIPAA compliant version. But as I said, there have been restrictions on using HIPAA compliant platforms have been relaxed for now, but they most likely will come back. So you might want to consider getting the HIPAA compliant versions anyways.
Thank you very much. We have another question from Elba Rosa. She wants to know, what do you mean by familismo? If you can explain a little bit about the term.
Sure, that's the connection or value of that Latino. So I don't want to stereotype as all Latinos have this high connection with their family members, family values, putting family first above other things, because that's not true. Not all Latino families are like that. But that seems to be something that is characteristic of some groups of Latinos. That's how I would characterize it, is that strong family value or prioritizing family above other things.
Amazing. I have another question. Can you briefly define Latinx and what that means?
Absolutely. So Latinx is actually a newer term that we are using to describe, that is a gender neutral term for Latino and Latina populations. And it's a term that's been adopted by the National Latinx Psychological Association, but it's supposed to be a more inclusive term for individuals who are transgender, who are queer, who don't identify with binary labels of female or male.
Perfect. And we have another question. How did you get trained in CBT? I have Googled it so many times and I cannot tell which website is eligible or not. Is TF CBT an additional training?
Well, I can say that TFCBT is a therapy that you can get certification in. So I think if you go to TFCBT web, there's an online training through the Medical University of South Carolina, but there's also a certification process if you wanted to be a national certified CBT provider, TFCBT provider in particular. That involves completing a certain number of cases and getting supervision for those cases in a certain amount of time and paying, I think, some kind of fee. But I can send out resources for that if you'd like. Not quite sure what kind of service CBT training is out there in general. My CBT training occurred in graduate school under the supervision of a licensed psychologist. But that's a good question, and I think I can help find some resources if you're interested in that information.
Yes, please. You can share. And the next question is, it is possible to provide sample consent form release, like if you can provide it?
So like a sample consent form for telehealth is what I'm hearing.
Yes.
I believe APA has come up with the materials for individuals to use. So the American Psychological Association has a telehealth resources website where they have some recommendations for checklists of the things that you'll need to provide telehealth. I don't want to say I know for sure, but they might have a sample consent form. And that might be a place that you look into for other resources about the materials, the forms that you need to get consent from clients.
Perfect. And the last question, because we are at 2 o'clock, it says, my biggest concern about remote therapy involves situations between family members or between members of a couple in case there is some sort of abuse present. Any suggestions specific to that, please?
Um, in terms of the use of telehealth, you would want to consider or do a risk assessment before you start treatment. And that might be one of the things that is an indicator to you about the safety of the client at home and whether starting telehealth therapy is the right way to go. You might need to work on keeping the client safe before you start therapy with them. So doing your risk assessment, being able to ensure that they're in a private location when you are doing your risk assessment so they can give you, honest answers and not be fearful of the responses. One way to ensure some privacy in general for telehealth is to recommend clients utilize headphones so at least other people can't hear what the clinician is saying. And maybe even the use of sound machines. Those can be helpful in covering up some of the noise that carries when people are doing telehealth sessions.
Thank you, Dr. Villalobos. Thank you, everyone that participated in today's webinar. Also, we want to thank the NLPA for this collaboration today. Remember also to fill out um, the G the Gibra. You have the SurveyMonkey link here on the slide, and also you have the QR code. Thank you very much for all your support. Thank you again, Dr. Villalobos.
Thank you. Thank you, everyone.
Bye.
Bye.